which we'll be saying much more about shortly. We're going to be recording this session, and so if you can switch off your cameras and mics, it'll help with people who catch up with this later. Obviously, if you're uncomfortable with the recording, please don't enter any information into the chat and so on. I'm Richard Graham. I'm a psychiatrist by training and the clinical lead for the Good Thinking programme, which we'll share with you a bit more about later. But we're going to kick off straight away in terms of discussing trauma, because we're very honoured that Dr. Nick Gray, a consultant clinical psychologist with profound expertise in the field of trauma and post-traumatic stress disorder, currently working with the Sussex Partnership NHS Foundation Trust, but some of you may know Nick from his former joint clinical director role at the Centre for Anxiety Disorders and Trauma at the Maudsley, or SLAM, depending on how old you are. Nick, it's fantastic that you're here and going to be sharing with us about the background to all the work I've been doing with Caroline. And I think you're going to be sharing some slides with us. So if we could start, and if this is not a moment where a traumatic experience might occur, finding the share function.
Sure, no, that's fine. Let me get that up, Rich, and then I'll okay, so I'm hoping that people can see a kind of a title slide at this point. So thank you for inviting me to kind of to do this introduction. I'm really pleased to be able to, and I'm really pleased that there are some kind of additional kind of resources out there for us all to use, kind of for people who've experienced kind of traumatic events, and particularly those with PTSD. And I'm really pleased that it's kind of on a platform that's going to be so accessible to people, which I think is kind of really, you know, kind of very important. And I know will go wider than London. That is for sure. And it's also really nice to be able to support Caroline, having worked together clinically at the Centre for Anxiety Disorders and Trauma in the past. It's nice to be able to support her in this kind of the great work that she's kind of provided here. I'm going to talk for just really kind of a few minutes to try and put into context about trauma and PTSD and why this is needed and when it could be used and the kind of importance of that. And then kind of Caroline will explain in a lot more detail about the kind of the nuts and bolts of the workbook itself and the kind of the wider context of the kind of the sort of the project and the kind of the web presence as well. So what I hope you can see on the kind of slide now is a kind of a somewhat kind of complicated diagram, which is actually taken from NHS Education for Scotland, about what is trauma and some of the different terms that are used in this area. The slides that you see here, and I think the later slides will be kind of made available on the Good Thinking website, so you'll be able to kind of refer to these at a later time point. But some of the terms that you will hear in this kind of arena are around, for example, trauma, complex trauma, and also adverse childhood experiences. And adverse childhood experiences cover a wide range of types of experience that children may have, including things like parental separation or parental kind of mental illness, but also including kind of more sort of rank abusive experiences, which also overlap with this concept of complex trauma, which is essentially traumatic events which are multiple in nature, typically kind of repeated. Such events could also occur in adulthood, particularly, for example, sadly, kind of domestic violence, but also kind of experiences of refugees and asylum seekers, such as experiencing war, kind of the flight to kind of a safe country, or kind of being kind of tortured or trafficked as well. You'll see on the kind of the slide that there is also a bubble for single incident trauma. And of course, I think some of the terms that are in there that we could add to these in terms of other types of events as well. But it's also to acknowledge that kind of a proportion of the people that we see, certainly kind of in the population, a large proportion, will have had a single kind of traumatic event in adulthood rather than childhood abusive experiences or kind of multiple traumatic experiences. There are two other things that I've added to the NHS Scotland slide that I want to highlight. First is the role of COVID-19, which may be both kind of acute health crisis, but also chronic life-threatening illness. And in particular, one of the things that we know from both pre-pandemic data and emerging data now is that about a third of people who survive intensive care go on to develop post-traumatic stress disorder, PTSD. And PTSD is only one of the outcomes following kind of traumatic events, but it is one of the kind of probably the one that is most well studied, and therefore the one that we have kind of most confident data for. The other point that I wish to highlight is that the events that we see on the slide there are sadly not evenly distributed across society, that those populations that face systemic discrimination of one sort or another are much more likely to be experiencing these events and may be less likely to easily be able to kind of access kind of services kind of in response. And it's just to kind of to acknowledge that. Some fairly sobering statistics on this slide, which I won't talk through in detail, but will allow you to kind of both read yourselves and look at kind of if accessing the slides kind of later. But that really kind of, this is in the UK, that kind of a quarter of all children will have been exposed to domestic violence by the age of 18 witnessing it, whether it be a one-off event or whether it be kind of more happening more occasions. And similarly, kind of fairly well-established data is that about a quarter of women will have experienced rather domestic violence. And it's not only women who experience it, but it is almost, you know, a very highly proportion of women that would experience it. That most people, most of us in this room now, will experience a traumatic event in our life at one point or another, and then about kind of 1 in 5 to 1 in 10 of us will kind of develop PTSD following such a traumatic event. The rates are different between men and women, at least in part because of the different events that men and women typically experience, and that it's much more likely that women are going to experience sexual assault or kind of sexual violence. And it's known that kind of sexual violence, sexual assault, are much more likely to lead to post-traumatic stress disorder than other kind of traumatic events. And across the UK, there are a large number of people who would meet criteria for post-traumatic stress disorder, which means really the kind of the reach of the kind of the working with trauma, coping with trauma workbook has a, you know, a large opportunity for kind of to reach many people, I would hope. And that in the average GP practice, there are about 100 people who would meet criteria for PTSD. And we know from the data that not nearly kind of probably about sort of 10 to 15 of those may be kind of accessing kind of treatment for that kind of PTSD. So sobering statistics. The thing that I want to just clarify for us all and is about some of the terms that we also hear in this area, which is one of the kind of the things that we're hearing much more of in the UK is around the idea of trauma-informed care. Again, typically kind of this has been led by Scotland and NHS Education for Scotland, but that trauma-informed care is for everybody within all healthcare services and really wider than simply healthcare as well. But that within kind of healthcare and mental health care, there are a proportion of people where a trauma is an important part of their history. So there will need to be more focus on the impact of traumatic events. And then on the far right of this kind of bar, what we can see is a smaller proportion of people who have PTSD or complex PTSD who need trauma-focused therapies. And my reading of kind of Caroline's great kind of workbook is that it's aimed particularly at people with PTSD and complex PTSD, but there will be ideas in there which will be helpful to people where trauma has been an important part of their history, even if they don't kind of formally meet criteria for kind of for PTSD. And then the final slide for kind of for context is what looks like a somewhat complicated slide. It's kind of from British Medical Journal from just a few years ago, thinking about the different types of trajectory of PTSD symptoms after people have traumatic events. So across the bottom, we have kind of the passage of time, and up the kind of the left-hand side, we see is the kind of levels of kind of PTSD symptoms, whereas the higher up you are, the higher level of symptoms. So what we can see there, to highlight two of the lines, is the kind of complete blue bar where there's a peak of symptoms, which then reduce it within the first month. And kind of then at a low level again. That's what's been termed here a resilient response, and is probably the most common response following a traumatic experience. that people have unwanted kind of nightmares or feeling jumpy in the first few weeks following an event, but then those kind of typically resolve in the kind of the weeks or month kind of following that. And then to highlight another one is the kind of the dashed sort of blue lilac line, which is where there typically aren't kind of many symptoms in the first kind of months or years even, but that with a later kind of trigger or a later kind of incident, there may be delayed onset kind of PTSD symptoms. What we can see that there are many other kind of potential trajectories, the yellow kind of dashed line being symptoms kind of being high and remaining high. And this is really a picture of chronic PTSD. But other kind of trajectories there as well. Apologies if you can hear the dog barking in the background. That's one of the other kind of joys of kind of being at home. But one of the things that I wanted to highlight with this slide is that actually for different people at different points in their kind of journey of recovery following traumatic events, that the kind of the coping with trauma workbook will be helpful to people. For some people, relatively soon after their traumatic event. For other people, maybe many years later. Yeah, and that there will be tools in the workbook that will be helpful to people no matter where they are in their kind of trajectory. With that, that's all of the context I think that I wanted to kind of to share. Hopefully, if I stop sharing now, and really wanted to hand back to Richard and to Caroline to really kind of talk through in more detail the great tools that they've outlined in the workbook.
Thank you very much, Nick. That is a really amazing introduction. It would be lovely for you to be able to stay and perhaps answer a few questions, but we know time is tight. All I can say is we've had some absolutely fascinating email exchanges, and perhaps there'll be some follow-on events, but thank you for that overview and really highlighting, which is very much what's driven this development, that the demand is much greater than what we can meet within the NHS. And let's stick with the facts, let's stick with the reality and actually come together to see what we can do to support all those who are struggling. So thank you enormously. We'll make sure those slides are available, and if there are any questions later that we think might be very good for you to sort of answer, we may dare to get in touch. But for now, we'll leave you to get on with your other work, and thank you again.
Thanks, Nick.
So that's such a fantastically helpful introduction. So just to give some context, some of you may have heard of the Good Thinking program, others may be new to it, but it was a development that was started, as did IAPT, as a response to that research in 2007 showing the 1 in 4 people who had some sort of mental health need, and only 1 in 4 were likely to be getting help. Even with IAPT, further research from Public Health England indicated that Londoners wanted different responses, and in a way, Good Thinking has evolved. I'm increasingly thinking, although we use digital technologies, but actually what we're trying to do is provide support that can work at scale, that can be accessible in different ways, and is essentially a development in terms of health inclusion. Now, early in COVID, Shelley Aldred, who was mental health leader at Public Health England, and I got together to look at how we might want to be thinking about a response to the needs likely to emerge from COVID. And as Nick has outlined in his first slide, post-traumatic stress was one of those sort of complications of people who were in quarantine, in isolation, and it almost seems laughable now that the stats at that time were for periods of 6 weeks. So we wanted to respond and looked around in terms of what was there in terms of apps and resources, and there was some content for veterans with military experience, but actually there was quite a gap. We were also learning with lockdown that GPs and other practitioners were valuing workbooks because they could print those off and give them to their patients, their clients, in a way to support them if they were living in digital poverty. At that point, Caroline and I started a conversation about what we could do. As I say, there was very little out there. And in fact, when we reviewed what was accessible, Caroline, in terms of websites, there wasn't simple, relatable content that would be accessible for many of the communities. And as Nick was saying very clearly, people who are disadvantaged, those areas of inequality, they're going to be more vulnerable. So, you know, creating something that isn't accessible was not going to help with the problem. And I think at that point, Caroline, we came to the conclusion that what would help is something quite simple, accessible in terms of design, and that the coping with trauma in terms of grounding techniques and other techniques might be something that any GP, anybody working with refugees, anybody working with violence reduction would have a bit access to be able to share. So we're going to walk you through the workbook so you can get a sense of it, tell you about some of the developments. There'll be time for a few questions. But I thought, Caroline, I mean, Nick gave an overview of the different situations in life where somebody might end up experiencing trauma. And I just wondered whether, to start the ball rolling, we might want to revisit what it feels like when you have a traumatic experience and on what sort of responses you may have to that, all of which are, in a sense, ordinary.
Mm-hmm. Yeah, sure. Yeah, so Nick's obviously said some of the things that can cause trauma, PTSD. And what we really wanted to put in this book was just a really helpful explanation that normalizes some of the responses that people might have following a traumatic event. So the first section of the workbook talks about what a traumatic event is, and also says, you know, you might have emotional responses such as fear, anger, sadness, shame and guilt, helplessness, horror, confusion, but also feeling numb or disorientated or overwhelmed or even spaced out. So we tried to keep the language as kind of simple as possible and not make it too technical or academic, just so that most people could relate to it. Then we talked about how people might have repeated distressing memories of the trauma, or see pictures of it in their minds, or feel as if it's happening again in the present, or re-experience the traumatic event as if it's happening in the here and now. And then we talked about how they might have disturbed sleep or nightmares. And then the avoidance symptoms of PTSD, avoiding people, places and reminders, and also feeling jumpy, easily startled and always on the lookout for danger. So we mentioned that these reactions are normal and they might fade on their own after a few weeks, particularly if you have support from your loved ones or and close friends. But we also said that if these reactions continue or start to affect how you live your life, then help is available. You know, there are therapists in the NHS who can support you to recover.
And I suppose one of the points that we'd want to make at this stage, Caroline, is we're not considering this a substitute for specialist therapy.
No.
But it may help someone who is thinking about it, who's perhaps even on a waiting list. But as we also know, lots of people are very wary. And one of the things that strikes me about people having access to this is, and particularly the videos that we'll signpost people to later, is it also helps you understand that there is something that can help. And that's a really important message for when people are reliving such distressing experiences.
Yeah, and something that I notice whenever I work with clients with PTSD is that normally in the first assessment session or the first session where you kind of go, oh, look, this is normal, you're not going mad, people find that really reassuring. Yeah. So we thought to have that in the workbook straight off, it might give some people some reassurance that what they're experiencing is PTSD, they're not going mad, you know, there is help out there.
And perhaps at this point, I think we've already had a request in the chat to actually show people what this workbook is. So I am now going to do something on a high wire called sharing my screen, and this will probably start looking right. Now I'm hoping, can everybody see that? Is that clear for you, Caroline? Probably.
Yes, yeah.
Yep. So this is what the workbook is, what you see. And as I say, Caroline and I spent a lot of time thinking about designs that would make it relatively sort of calming and simple and accessible. And you can download this as a PDF from the Good Thinking site that we'll show you at the end, and other things. So the first part is very much covering what Nick and Caroline were discussing in terms of the context, and this is a slightly updated version for Afghan refugees, where they can also scan that QR code. We'll update the one on the site, and that will take you through to the section of Good Thinking where Caroline goes through the grounding techniques with video explanations. So you could actually signpost a client to a particular grounding technique. There's then the list, and of course then inevitably support for people who are in crisis. But Caroline, we're going to just go through these techniques one by one to give people a flavour if they're not familiar. And as I say, the videos are there as backup. So technique number one, something called a grounding statement.
Sure. Can I just say something before, Richard, which is as we were preparing this book, I did use it with clients in therapy, and also introduced it to some clients who attended a post-ITU recovery group post-COVID. So we got quite a lot of feedback from users along the way, which we incorporated in the book, just to let people know that.
Yeah, that's a really important point. Yes, sorry, Caroline.
No, that's sorry. So the first technique is a grounding statement, so made up of a few positive words to remind you that you got through the trauma and you're surviving in the present. So things like, I'm safe now, it's today's date, the trauma isn't happening now, or I'm here in my office, I'm sat in my chair, this is not the place where the trauma happened, it's not happening now and I'm safe. And we tried to make the imagery just quite neutral. And we also wanted to include a bit where we sort of said you could acknowledge your feelings in your grounding statement, such as, I am feeling anxious, but I know that I'm safe. I survived the trauma. And then we've got some space there for people to write their own.
Which I guess is important, because when they are starting to relive something, being able to go back to their own grounding statement are really helpful technique itself. So that's the first one. We're then going to move to an area that perhaps some people will have heard about, which is grounding using the 5 senses. And so each of our senses can help someone feel they're in the present again. Yeah,
absolutely. So the whole point of all of these grounding techniques really is to help people feel safer in their current environment, and to just remind them that the trauma is not happening again. So using your 5 senses, you can do this. So, for example, using your sight, having a look around at what you can see, perhaps looking at different colours or counting things can be helpful if people are trying to stop themselves going into a flashback. And getting people to really focus on what's in their environment that's telling them that the trauma is not happening now. You know, is it a different time of day? Is it a different place? Are they in a different room? So just trying to get people to have a good look round and really focus in on the details to kind of ground themselves in the present. And similarly, you can do that with sounds. So are there any particular noises that you can notice? Can you focus on them one by one? A bit of attention training there. What sounds are close by and what are further away? Just to take your attention away from the flashback, if that might help. And also maybe some people might find it helpful to listen to music or a podcast when they're getting trauma reminders, just to remind them that, you know, it's different now. They're in a safe place. The trauma's not happening now. Smell is one that we use quite a lot. I think we all know that smells can be very nostalgic and take you, you know, the smell of freshly cut grass might be very pleasant for people, or baking might be a really pleasant smell and take you back to some positive memories. So sometimes that's really helpful for people when they're having a flashback. They could find a smell that they like that makes them feel safe or reminds them of a happy time. And then they can just make it portable so that if they find they're having vivid memories or a flashback coming on, they can just sort of whip it out of their pocket and have a smell. So we would ask people to experiment with that. Some people use lavender, but for other people, they might hate lavender, or it might be associated with a bad memory. So I think it's important for people to have an individual smell that works for them. And then with touch, so sometimes people find it really helpful to find an object that they like. that they can associate with good memories. And ideally, we would want it to be something that they've had since the trauma, and it could be small and good to fiddle with. So it could be something like a key ring or a fidget spinner or a pebble or something. And then when you feel a memory is coming on, you could just focus on it. You could just play with it, touch it, see what it's like. I've worked with some people, for example, refugees, who have found it really helpful to have, say, a key ring of a London bus or something, because that reminds them that they're in the UK and their trauma's not happening now. Or other people who've, you know, got through a very difficult time and then have a picture of, I don't know, their children or something that's been taken recently that reminds them of a good time that happened since the trauma. So yeah.
And then finally, taste.
Yeah, finally taste. I was just going to say another couple of things that people could try with touch as well. Sorry. If they don't have anything to hand, then they could just, you know, feel the arms of their chair, or really focus on the floor beneath their feet. Anything to ground them in the present. You know, what does my chair feel like? Is it hard or soft? You know, what does the floor feel like? Is it warm or cold? You know, touching a wall, something that they can use their sense of touch to kind of ground them. And sometimes in therapy, we might use an object and just sort of throw it back and forth between each other if it helps people kind of come out of the flashback by focusing on throwing and catching something. So all of those things people could use if they find helpful. And yes, finally, taste. So some people get flashbacks and they might taste things again. Perhaps they might taste blood or something in their mouth, and so you could just replace that, for example, with a peppermint or some chewing gum or something. And sometimes it might not be because you're having a flashback that involves taste. It might just be that, you know, sucking an extra strong mint brings you out of your flashback because it's quite a strong taste.
And I guess pretty much all of those techniques are, as you mentioned earlier, portable in terms of the things you can carry with you, or are accessible in the moment. And all of them, different people will tune into different senses in terms of what helps them, perhaps related to the trauma, but they can all bring you out of that flashback and back into the safe present.
Yeah, and that's one of the things that we want to stress with people when using the workbook is, don't worry if you try something and it doesn't help, because it might just not be the thing that works for you. Try a few different things and find something that works for you. And also sometimes people find it difficult and these techniques need a bit of tweaking. So it might be that, you know, if it's not working for them, it's not because there's anything wrong with them. It might just be they need a therapist to go through it with them, or to try and give them some extra support, or for them to just try a few different things. So we try and address that in the book.
Yeah. But also you're bringing up that this can actually be helpful in the course of therapy as well, because it can help you between sessions remember what techniques helped.
Yeah. And I've certainly, when I've used it in sessions, you know, I might have tried something and then people might say, oh, you know, that didn't work for me. So we have a little think, we problem solve it and try a different technique, or try a variation on one of these techniques. You know, maybe they just need to change the smell to something that's a bit better or a bit happier or something. So, yeah.
Well, that is quite a list for the senses technique, but we've still got a few to go. Body movement's a really interesting one. Do you want to tell us how this technique can help someone?
Yeah, so sometimes when people have a flashback, they might move their body or feel like their body is stuck in the way it was at the time of the trauma. So, for example, if I was imagining, you know, if I'd been attacked or hit, I might go like this at the time of the trauma. And then when I have a flashback, I might also go like this. And that's not really doing much to tell my brain that the trauma is not happening now. So if I could move my body differently, even if I am having a flashback, and just sort of, I don't know, stretch my arms out or move slightly differently, sometimes that can be enough to kind of break the mind and body connection and make your brain realize, oh yeah, the trauma is not happening now. So I've used this for people. Sometimes people talk about maybe they might have felt trapped at the time of the trauma, or perhaps they couldn't move. So we would say, okay, why don't we just try moving your body differently? Shall we stand up? Shall we walk around? Let's show your brain that the trauma is not happening now. Let's move in a way that perhaps you couldn't at the time, just to reinforce the fact that the trauma is over and you're safe in the here and now.
And I think we've discussed, and it's not hard to imagine that this can be particularly helpful for refugees with their journey to the UK.
Yeah, definitely. And one of the things that we say in the video, sorry, Richard.
Yes.
One of the things that we say in the video, because we're actually doing it as if we're doing it in a therapy session with my colleague on the video, and he was describing not being able to move in a car crash because the seatbelt was on.
Yeah.
And so we're sort of saying, you know, even if some people find it really hard to move their body differently when they're in the middle of the flashback. So we were saying, you know, if that feels too much, then maybe just try and move, you know, small movement like a finger or another finger, and then work up to a bigger movement just to kind of help you come out of that flashback.
And again, there's space there to write down what might work for you to give you a little prompt. Great, but there's more. We now have updating, which I guess is pretty key to a lot of the techniques. Yeah.
So this is technically, it's an updating technique that we use in therapy rather than a grounding technique. Mm-hmm. But basically it's to try and remind yourself of what you know now. And that could be as simple as I am safe now, or, you know, now I know I didn't die. But it could also be used when we're using it in therapy. It might be part of the kind of updating the difficult beliefs that someone might develop at the time of a trauma. For example, if they felt guilty for something, lots of people when they have PTSD blame themselves and feel guilty for things that are not their fault. So when you're looking at that in therapy, you might kind of do a bit of work on it and think about the evidence of that belief and what they know now. So, you know, you can update that and say, you know, I did feel guilty, but now what I know is that it wasn't my fault and I am safe and I didn't die. And that's a helpful technique to use.
Great, thank you. Another really interesting one, I guess, sort of similar in some ways to what you've just been saying, is the same different technique.
Yeah. So again, it's about, so people often spot what's similar with trauma. So for example, you know, if I had a traumatic event that was on a grey, cold and rainy day, you know, I might notice the weather is outside, it's grey, cold and rainy, and I might have a lot of memories triggered by these environmental cues that are the same. We often focus on what's the same because that's a good way of keeping us safe, but sometimes we can get too overwhelmed by that and we need to remind ourselves about what's different. So it might be, you know, yes, it is cold and rainy, but actually I'm safe, I'm not being attacked, or I'm not in a car crash, or whatever it is, and think about everything that is different, because otherwise it's like our emergency alarm goes off and we think that everything's dangerous all the time. So we want to help people manage their sort of sense of threat, and looking at things that are different rather than only focusing on the things that are the same can really help that sort of turn down the sense of threat.
Well, there again is quite a nice simple design that most of us can relate to in terms of differences in those two pictures. I guess we'd call it spot the difference when we were younger, but has a still powerful way of breaking through when someone's reliving those.
And one of the things is it's not just about the environmental things that are the same. So as we say in the book, you know, yes, it's sunny today and I'm on my bike just like at the time of the trauma, but all these other things are different. Sometimes the cues can be internal. So I might be anxious about presenting something, and that reminds me of the anxiety I had at the time of the trauma. So it's about spotting what's the same, whether it's an external cue or an internal cue, and then about what's different. And it's also good when I've worked with people who've been through lots of trauma in the past, it's good for them to think about what's different about them. So for example, you know, I was a child then, now I'm an adult and I could get help, or, you know, now I'm taller and I could protect myself or get away or escape or something. So there's lots of things that you can look at that are different that might help people feel safer in the present.
Thank you. Moving on to the next one, we're getting into areas that I often think are more abstract, but of course I'm not experiencing those flashbacks, which we're going to have that very strong visual aspect to them. So imagery work is another technique that can support people.
Yeah, so there's a few bits to imagery work. So sometimes it's about turning down the intensity of the flashback image. And so the first bit of this page is about techniques such as trying to put the image that's coming into your mind on an imaginary TV screen, and you've got the remote control. Try and make the image go blurry or black and white, or see if you can move it further away, or see if you can fast forward over it or turn it off. Sometimes people find that that's enough to cope with distressing images. The other thing is that we can try some imagery scripting. So with what we're trying to explain to people is that, you know, these images are memories, they're coming from your head, they're inside your head. So the good news is that you're in charge and you can change that. You can, like a director, you can change the script. So whilst we can't change what happened during the traumatic event, if you're stuck with a distressing image, you can change the image in a way to make it something less frightening, for example, by removing the blood or making the scene look more peaceful, or imagine someone you trust helping you in the scene, or imagine even painting over the image and wiping it away. And again, this is something that people have to sometimes work on quite a bit to find something that works for them. So sometimes people might find putting it on a TV and making it go blurry is fine. Other times people might need to change the image to make something look a bit more peaceful. And at other times people might want to re-script it and imagine like someone they care about telling them it's going to be okay and they're going to get through it. So something that works for you, but you might have to work with someone on this just to help them tweak it if they need to.
And it reminds me that in the videos you made with your colleague Tom Parslow, that you do work through different versions of these techniques. So it gives people an idea of, you know, it isn't just the one way. There are opportunities to keep trying until you find something that works.
Yeah. And I guess it's important to remember, obviously, though, sadly, you know, we can't change the outcome of the trauma. So it's no good changing the image. If the feared image is of a loved one dying, you can't change the image to where they're alive again and everything's fine. Obviously, that's a very sad thing, but it's true. But what you can do is try and make that person be more, you know, that scene look more peaceful, or try and erase that scene so that or replace it with another memory that's nicer. Something that makes it less distressing for that client. Yeah.
And then the final technique in the workbook is nightmare rescripting.
Yeah. And again, it was one of those ones where it's not strictly a grounding technique. So all the ones after the grounding techniques over the 5 senses, these are other techniques that we would use in therapy. But it's something that people have quite commonly, and we thought if we could actually help people with their nightmares, you know, it might be something that they need to go through with a therapist. Again, sometimes it's difficult, this technique, and it does need a bit of tweaking. But again, we're saying, you know, nightmares are scary, but they are only happening in your head. So if you were a film, you'd be the director, and you can completely change the script. And also your special effects budget can be huge, so you can change it to how you want it. So what we ask people to do is to write down what happens in the nightmare and then look over it and decide at what point you want it to change. Now, you want them to re-script it from the moment before it gets bad. So some people will say, oh, you know, I had this dream and I knew that it was the nightmare starting because I was in this house or something. And you go, okay, great. So the minute you know that nightmare starting, we want to change that script of that nightmare. Get rid of what they've written from that point on and rewrite the script with how they want the dream to go instead. And anything they like can happen. So they're the director and they can be in charge of special effects. They could be a superhero. They could fly out of there on a unicorn. They could do whatever, you know. Sometimes people have quite bizarre or surreal ideas and they tend to work really well. But I don't know why, but maybe just because it's a dream thing. So I've had people say, oh, you know, I imagined that I flew off on this creature and then I went into another world. And it's like, great. And then they didn't have the nightmare again. So it doesn't have to be anything. Yeah, it can be whatever they want, as long as it involves them being safe or getting away from the danger. And then you want them to describe that, write it down in lots of sensory detail. So what could they smell, what could they see, what could they taste, and then to read it to themselves a few times before they go to sleep. Yeah. And I always say to people, you know, don't worry if it doesn't work straight away. We might just need to tweak it a bit or see what works for you.
Thank you. So that covers the techniques. It reminds me that in addition to your sort of kind of co-creating how effective this was with your clients, we did also have quite a lot of input from trauma experts, Chris Bruin, Edith Albert, and as well as Nick Gray, of course. So in terms of this being evidence-based and sort of having the voice of the user in the process, that this has all been incorporated into these techniques.
Yeah.
Just finally, for people who may want to take this a bit further, we've linked to other resources on the Good Thinking site, and I'm just about to show you that, as well as other resources in relation to post-traumatic stress. And you'll see under other useful resources, sort of almost just over halfway down, the Refugee Council Therapeutic Wellbeing Resources, because this is a version that has been adapted for Afghan refugees, and we'll come back to that shortly. But this is all customizable for different areas, different processes. So we could have almost like a hospital COVID one, something in relation to terrorist incidents and so on, that would all be there. So it's a flexible resource as well, where we can build things into it. And there's also that very nice acknowledgement, Caroline, to your clients who have helped you understand this field better.
Yeah, definitely. I wanted to acknowledge the clients. And also, you know, these techniques are not, I didn't invent these techniques. These are tried and tested therapeutic techniques by a variety of different, you know, leading trauma experts. So I wanted to acknowledge the people who developed these techniques, but also the clients who'd helped with the making of this trauma workbook.
I'd just like to show everyone on the call now, and I don't know, Samira, my colleague from Good Thinking. Oh dear, that's we may need to come back to that. Let me just check. It looks like we've got a problem with Good Thinking itself.
It's up and running again now, Richard.
Thank you very much. I work with a great team. There's a crisis, we solve it. I'm going to go back just to show you how to find these resources on Good Thinking, and hopefully Caroline or Jess, can everyone see that okay? Mm-hmm. So this is the Good Thinking site. We're going to go through a redesign, so it's going to look even more attractive very soon. Lots of areas for audiences, and the faith and belief communities has translated content that may be very accessible for people you're working with. But the section where the Coping with Trauma workbook is under the canny title of workbook. And as you will see there, the Coping with Trauma for Better Mental Health workbook is at the top. And as you go into that, two things to notice. One is, as you click through to the workbook, you will see in the top right corner next to the little printer icon is a button to download, and when you download the PDF, that is shareable. You know, we're very much grateful to Caroline for working with us to develop this, but really, you know, this is a free resource that can go to whoever will make use of it. But probably most importantly, and some of the sort of context that both Nick and Caroline have given in terms of, you know, who's it for, how could it help, etc., and what the limitations might be there. But also we've got in video form, Caroline and her colleague Tom Parslow going through each of those techniques. I mean, at the moment, these are embedded in YouTube, so you can give people a link to each video. I'm not going to show them now because it gets complicated sharing audio, but all the different grounding techniques. So if something is particularly helpful for someone you're working with, there is that, but including where to go for support, including references to what IAPT and other psychological therapy services would be able to offer. I would still go back to the fact that when Tom and Caroline are talking together, they're not just saying this works, you know, and straight off. It's actually, I think, a really nice introduction what having therapy, psychological therapy for post-traumatic stress might actually be like. And I think it's very relatable. And we're hoping that this is going to be something, again, we can provide in different languages and possibly even share with community leaders who might do their own sort of versions, but certainly we could dub Caroline into many different languages as well, I think. It might be nice, Caroline, you've been working extremely hard, not only on the workbook, but during this webinar as well. If there are a couple of questions that are in the chat, I don't know, Jess got some nice ones. There's one comment here about complex PTSD and dissociative disorders. This is from Alexandra Wald, Central London Community Healthcare Trust. I mean, Caroline, I don't think we are assuming that this is going to replace specialist services, and I'm just thinking of Nick's sort of bar chart of different needs, really.
Yeah. I think, I mean, I use all of these techniques with people who are very dissociative or have, you know, complex PTSD and dissociative disorders. I use, and I would give a client that I'm working with this book. Obviously, it doesn't replace, this is not going to replace trauma therapy, because although it's got some aspects of mainly grounding and stabilizing techniques with a few updating and imagery scripting ones, obviously you need the working on the trauma memory component in order to treat PTSD, which you only get whilst working through it with a therapist. I think I saw that question come in and it said, what about signposts? I'm not sure if it said, what about signposts?
Yeah, no, it did. Yeah, you're quite right, Caroline. Yeah.
No, we could certainly include a link to those services. I think it's a bit difficult in terms of knowing which services are actually open and don't have, in terms of have open waiting lists and don't have really long waiting lists. So I think at the minute, that's why we had those resources on there.
Well, actually, you remind me, on the first page, there is a link to the IAP service finder.
Yeah.
Which is now available via gov.uk, and so if you type in your postcode, I think, or GP, that will connect you with the IAP service, who could then also help with signposting. So we've tried to make sure the crisis lines, you know, they're all hosted on Good Thinking. I won't go and show you where they are now, but there are sort of links to IAPT, to the crisis lines. And so we're trying to integrate this as best we can, just recognizing, again, going right back to Nick's kind of daunting statistics, really, that the need was outstripping what any specialist or even IAPT service could provide, or primary care for that matter. So thanks for that really helpful question. Sorry, Caroline.
Just to add to that as well, a lot of those services that are specialist services for complex PTSD and dissociation, they would require a referral in from a professional rather than a self-referral. I appreciate the point that some people are saying that, you know, some IAP services won't see PTSD. My understanding is that they are supposed to, and that most IAP services now are training people in you know, EMDR as well as CBT for PTSD. But there is also, people can also go to their GP and get a referral to a specialist service. So it might be worth mentioning that to people if there's problems with them accessing services.
But just being pragmatic about it, even if your GP does that, you are not going to get an appointment immediately. And again, the coping with trauma workbook hopefully makes it feel less unusual what you're experiencing and gives you at least something that could reduce some of the distress. So I think that was very much our approach, wasn't it, Caroline? We're living in a real world. We're not denying some of the boundary issues that happen within the health space or some of the challenges around demand, but let's see what we can do. And I would still think that there will be a number of people who are struggling with trauma that don't feel ready. And actually, if this is also as a sort of educational tool, helping them understand better and helping them think help is available. It's you know, just something that's there. Thank you, Joe Stubley. Very nice to hear from you. We are trying to help. Any further questions that, here you are, you had Nick Gray and now, a really experienced, I didn't even introduce you, did I, Caroline, as a cognitive behavioural therapist at the Centre for Anxiety Disorders and Trauma at the SLAM. Yeah, actually, there's another question from Alexandra Wald about GPs. One of the drivers of this project was a GP in Newham, Imrana Siddiqui, who collaborates with us a great deal, and I think mentioned that in terms of all those things that Nick was describing in terms of trauma and inequality, Newham was a borough that really struggled. And she's been, oh, there you are, Imrana Siddiqui. And we are looking at how to make this even more accessible. Imrana, do you want to say a few things as a GP working in a borough which has so much trauma, residents struggling with so much post-traumatic stress?
Yeah, thank you, Richard. No, I think you've really said it all, actually. So as Nick described as well, how this can be used in so many different contexts. And so as you've described, the patients I see won't often relate to PTSD as that diagnosis, but they represent their trauma in so many different ways. But even in those patients, I can see how this would be very helpful. And as has been alluded to in the chat, and what we're working on is if we can make it more relatable to those different communities, it will be even more useful. And just quickly to, so if you don't mind me hijacking, there's a question about GP training around trauma. So would you like me to try and attempt to answer that?
Well, please do.
So, I mean, I can't speak for all of London, but within North East London, within the CCG and within our mental health transformation, there's a lot of focus on trauma-informed care within our system. So there is a system-wide approach happening in terms of upskilling GPs and all of primary care for, in the concepts of trauma and trauma-informed care. So that is something very much in the pipeline.
Great, and just to add on to that, also we are doing some training with GP trainees in the South East London sector coming up soon on trauma.
Yeah, great. I just want to share one more thing which very much relates in Imrana to your work with us, and Caroline will know of this as well. This is something that can be translated as well, and by the end of the week we should have a version of the Coping with Trauma workbook for Afghan refugees translated into Dari and Pashto. I hope I've got the languages right, but just to give you a taste of how that might look, I'm just going to share something that we've been doing with Thrive London. Sorry, before I share, I've got to go to a different tab. This is in Dari, the 5 ways to well-being. We're finding, and Imrana has been again so helpful in this, that when we can translate materials into the language and bring in both scriptural references related to their faith, as well as designs that fit better with the world somebody is either coming from or lives within, that we can again customize this to fit with many different faiths, many different languages. I'm going to stop there because this isn't the final version of what that version will look like, but as tragically, more refugee communities might seek asylum in the UK, then this version will be in the bridging hotels where refugees arrive, and there will be support from Caroline and links to the videos to actually help them if they are reliving. And Caroline, you're going to be supporting some of those that experienced the trauma of the Kabul airport bombings. So again, to have that in your first language to support, and I think we're going to be producing more videos, as I said.
Can I just mention something else as well? So I was able to do some work with Melanie Abbas and the Friendship Bench in Zimbabwe a few years ago, and actually Melanie's mentioned that she's actually getting this translated into Shona to try and use it as a resource out there as well. So it's quite good that people are trying to translate it and use it widely, see if it can be helpful.
Yeah, there's a couple of comments. I mean, we're nearly out of time about addiction and very much early on. I think there's a reference to those coping strategies, Caroline, that are not going to be helpful.
Yeah, I mean, certainly, I know it's really hard for people who have addiction issues to get therapy. I mean, the waiting list for PTSD therapy anyway is quite long, and when it's complicated with addiction problems, which are a way of coping with trauma and managing flashbacks for a lot of people, sometimes those people can be refused access to treatment. So one of the things that we wanted to, you know, again, perhaps use this book, because people may not feel the need to use substances or alcohol to kind of harmful levels if they were able to manage their flashbacks and things in other ways. So hopefully this might be a helpful resource for people with addiction problems too.
And I think that echoes what Joe Subley said about stabilizing almost before you can get access to support. So hugely helpful to frame it in that sense. Just one other comment about translated versions. If you can remember the Good Thinking site, but we'll try and send out Nick's slides and the URLs to the different parts of Good Thinking where you can access this. But in the faith and beliefs community section, we're going to be having increasing amounts of translated content, but also, as I said, culturally competent in terms of faith and beliefs too. And so we should be able to upload the one for Afghan refugees, hopefully within a week or so, and that will grow. So keep checking back and sign up to the newsletter where we can keep you updated in terms of new content, but absolutely more translated, more culturally competent resource that you can share, print even. So this newsletter is on the front page if you scroll down of Good Thinking, Alexandra, but we'll make sure we send out in the email because so many of you signed up to this, and so many, you know, this has been a huge success in terms of the number of people who have come together today. So thank you all for attending, but I do want to thank you, Caroline. We had quite a journey with this, and yeah, everything from copywriters and designers through to trauma experts. We lived it. But if this can, you know, reduce the suffering for some who by no fault of their own, as you indicated, are reliving terrible experiences, then we hope we've done something helpful. And you can just share this once you go there, share that, share Caroline's videos. And I guess the only other thing to say is if people are interested in more themed webinars on different areas of trauma, like intensive care and COVID, knife crime, violence, refugee experiences, because there are subtle differences, I guess, Caroline, in your work where you're going to tune into their lived experience. So we could follow this up if there's an interest. So do let us know. But any last thoughts, Caroline, just as we come to the end?
No, I would just say, you know, please use it as you see fit, and you know, hopefully it will work. Some of it will work for some people, and just let them know that if it's not, then they might just need to tweak things or go through it with a therapist. So, yeah. Right.
Well, thank you again, and we'll send our thanks to Nick one more time, and thank you all for attending this webinar. This is recorded, so this will also be available via Good Thinking if you want to share it with any of your colleagues. We'll try and get this up as quickly as we can. It's one of the easier things. And keep well, stay safe. I don't know what one says in Omicron days, but it's been a pleasure to be part of this project. And thank you, Caroline, one more time.
Thank you. Thanks, Richard.